Good morning, good afternoon, good evening, everyone, wherever you are in the world. Welcome to this WHO RSV Roadshow web series. I'm Heather Zar from the University of Cape Town. It's a real pleasure to host this today, the first webinar in this series. This is a collaboration between the World Health Organization, between ResVNet, the RSV Foundation, and between PATH. And it reflects the very exciting and important time that we are at in terms of RSV prevention, with RSV being a preventable disease for the first time now in infants and to an extent in adults as well. And so you can see this partnership has put together a series of 7 webinars over the next 6 months. Today's one is a primer on the verge of RSV disease prevention. And you see there the other webinars covering epidemiology, effectiveness of these interventions, economics of them, surveillance, and finally, prevention in older adults. These webinars are based on the existing RSV Roadshow, a communication toolkit that is freely available for use. You can see the link at the bottom there, widely available. You can download them if you want, and you can use them yourself for presentations and for advocacy, for making these products more widely available. Those of you from high-income countries will know that many high-income countries have licensed these products and are rolling them out. And unfortunately, as always, in low-middle-income countries, the implementation is lagging. And today's webinar will focus on some of this. We will have a presentation firstly on the verge of RSV disease prevention, a primer, and this will be followed by some reflections from low-middle-income country contexts. Please submit your questions in the question and answer chat. Unfortunately, we can't have live interaction in terms of you speaking. There are over 500 people registered for this webinar today, but please put your questions in the chat and we'll hope to get to them. So it's a very great pleasure to introduce Danny Feikin today, who is our speaker. He received his medical degree at Harvard. He did his residency at the University of California, San Francisco, and did a master's in public health at the University of Colorado. He completed the epidemic intelligence program at the US CDC, and he continued to work for CDC for almost 20 years, mostly focused on bacterial and viral causes of respiratory illness. And he's been working at WHO for the last 7 years, focused on vaccination against RSV and against SARS-CoV-2, and of course, wider implementation globally. So Danny, it's a great pleasure to ask you to please speak to us today for the primer.
Thank you, Heather. Great. It's really an honor and a pleasure to be able to give the first presentation in the RSV Roadshow webinar series. We've had many people working on this webinar series for quite a long time, so it's great to see it all come together. As Heather mentioned, this talk is called On the Verge of Respiratory Syncytial Virus Disease Prevention. We also call it the primer. It will give you a high-level overview of RSV disease, RSV prevention products, and how to get those products introduced into countries. If you have time to give only one talk on RSV, this will be the talk to give because it touches upon on the high-level notes, but the subsequent webinars that Heather mentioned will go into deeper dives, greater detail for some of these subjects. I have 2 objectives today. One is to give you some information about the disease and the products. The second is to show you what the Roadshow series looks like. The formatting will be the same throughout. And you'll see what level of previous knowledge is expected in the audience. These are not slides that are meant for the RSV connoisseurs. These are meant to introduce people who know little about RSV but might play an important role in introducing these RSV prevention products in country. And before I start, I really want to thank our collaborators at the ResVNet Foundation and PATH and WHO for putting this webinar series together. And I also really want to thank the people and institutions that were involved in putting these slide sets together, and those of you who have volunteered or will be asked to volunteer in the future to participate in these slideshows. So let me start. Why RSV and why now? We've known about RSV for almost 70 years. We know that it causes severe respiratory disease in young infants, but it's only really been in the last year that we've had immunization products for widespread use. We have a maternal vaccine given in pregnancy, and we have a long-acting monoclonal antibody given to newborns. And we are hopeful that these products can make a significant reduction in the millions of hospitalizations, the hundreds of thousands of deaths, and the huge strain on health systems that is caused by RSV every year. As Heather mentioned, some countries, high-income countries, have started to use these products, and we are hoping within the next couple years they will become available to low and middle-income countries. And so now is the time to start raising awareness, start the conversation in your countries about RSV and RSV prevention. I'm going to cover RSV disease burden. I'm going to talk a little bit about these products and then move on to the steps needed to get these products into countries. Let's start with the virus. RSV is a single-stranded RNA virus. It has several proteins on the surface of the virus, but the most important one in terms of immunization is called the fusion or F protein. And you can think of this protein as similar to the spike protein on SARS-CoV-2 that you've heard so much about. This protein allows the virus to fuse with human epithelial cells in the respiratory tract and infect those cells. Eventually, those epithelial cells will die, and they, along with inflammatory white blood cells, will be sloughed off along with mucus and fibrin into the small airways. And in little babies, those airways are very small and they can get plugged up. And this obstruction is what causes the severe disease in young infants. RSV is very widespread. Almost every child will be infected by RSV before their second birthday. It often presents as a mild upper respiratory tract infection, like a cold, but it can be very severe and in some cases deadly. It's transmitted by sneezing, coughing, breathing, or touching contaminated surfaces and then touching mucosal membranes. An infection causes partial immunity, so that people tend to get reinfected throughout their lifetime. Adults tend not to get very sick from RSV, although in the elderly, people can get sick again. And one of the later talks in this webinar series will focus on RSV in the elderly. Now, the vast majority of children who get severely ill with RSV are previously healthy babies. They were born at term, they have no underlying illnesses, but because it's such a common disease, even a small percentage of them who get severe infection creates a large burden. There are additional risk factors, however, for severe disease, premature birth, underlying comorbidities, particularly heart and lung disease, and living in socially disadvantaged areas. Taking a step back and thinking about child mortality, pneumonia is still the leading cause of child mortality. 15% of all deaths under 5 are due to pneumonia. And if you want to prevent pneumonia, you're going to have to prevent RSV because RSV plays such a large role in pneumonia. So we're really talking about products that can potentially reduce overall child mortality when we talk about RSV prevention. The latest estimates of the global burden of RSV in children under 5 estimate that in 2019, there were 33 million episodes of RSV lower respiratory tract infection, 20% of which were in children under 6 months of age. There were 3.6 million hospitalizations, 39% in children less than 6 months of age, and 101,000 RSV attributable deaths. Almost half of those are in children under the age of 6 months of age. And this is important because that is precisely the age group that these new prevention products will protect. Overall, RSV accounts for approximately 3.6% of deaths in children under the age of 6 months of age. Another way of looking at it, in perhaps easier to understand terms, is 1 in every 28 deaths before 6 months of age globally is due to RSV. Now, even though this is a democratic virus in that it infects children worldwide, it is not democratic and it is not equitable in terms of which children are dying from RSV. 97% of deaths from RSV are in low and middle income countries. If you look at the graphic on the left here in high income countries, the rate of deaths is quite low, and there's about an equal number of deaths in the community and in the hospital. But if you look here in the middle, in low-income countries, the rates of death are much higher, and there are 4 deaths in the community for every 1 death in the hospital in these settings. And that's because these children are infected, they get sick, and they never make it into hospital care. And that's why RSV prevention, immunization is so important in those settings, because it will prevent children from getting severe RSV disease in the first place. This is a study called Verge that looked at severe and very severe pneumonia in 5 countries in Africa, 2 in South Asia, and in every one of those countries, RSV far and away was the leading cause of severe pneumonia. Overall, it accounted for 31% of all severe and very severe pneumonia episodes, much higher than any other pathogen. Now, although we don't think of RSV as causing neonatal disease, in this study of severe infections in South Asia, RSV, this is in children under the age of 2 months, RSV actually was the leading pathogen that was found in 6.48%. Now, RSV circulates in different ways in different parts of the world. In temperate climates and semi-temperate climates, RSV has a seasonal pattern of circulation. It peaks in the cooler months of the year. Around the equator, in the tropics, however, RSV tends to circulate year-round. The seasons are less well-defined. There could be 2 seasons in the same year. There could be different seasons in different parts of the country. Much harder to define the season in those settings. Now, the burden of RSV is not just on child health, but it's on health systems and it's on households. You can see here that in Malawi, for a hospitalized RSV episode, a household had to spend 32% of their monthly income. In Bangladesh, that was 24%, but in the poorer households, it was 32%. In Bangladesh, over $10 million are spent each year on RSV hospitalizations, and in 4 African countries, as part of Verge, it was determined that RSV accounts for 5 to 10% of all hospital admissions in children under 5. So obviously a clear burden on the health system. Now, if RSV is so ubiquitous, why don't more people know about it? Well, part of the reason is that in the past, in the clinical care, RSV was not tested for. And that's because there is no treatment for it, so there was really no reason to test for it. However, in countries that have done surveillance, it's quite easy to find RSV. It's an upper respiratory tract sample from the back of the nose or the nasopharynx and a PCR test. And in almost every country where RSV is looked for in young infants, it is found in great numbers. We need more surveillance in low and middle income countries. In an effort to do that, WHO's Global Influenza Surveillance and Response System, GISRIS, is adding on RSV testing as part of their platform in children in many countries, as you can see on this map in purple. Now let's move on to the products. On the left, you can see a timeline of RSV. RSV was discovered back in 1956. And within 10 years, there was already a vaccine for it. It was a formalin inactivated vaccine, and it started to be tested in the mid-1960s. However, tragically, the consequences of that vaccine were terrible, in that children who had never been exposed to RSV before and were vaccinated tended to get very sick with something called enhanced respiratory disease when they were first infected with RSV. And 2 children in that trial died. That put a chill on the RSV vaccine development for several decades. And it really wasn't until the 2010s that there were new breakthroughs that have advanced the science. The main breakthrough was that fusion protein, the F protein I mentioned before. It was discovered that it has two conformations, what's called a pre-fusion conformation and a post-fusion conformation. And more often in nature, you find the post-fusion, but it's actually that pre-fusion conformation that is the more immunogenic, the one that creates the better antibodies. And so researchers found a way to stabilize or lock the conformation into the pre-fusion form, and that led to the recent new products to prevent RSV. The first that was licensed in 2022 was a monoclonal antibody, a long-acting monoclonal antibody called nursivimab, and then a year later was the maternal vaccine called RSV Pre-F or Abrysvo, and there have been two products that have been licensed for older adults, Abrysvo and another vaccine called RSV. On the right, you can see what's called the RSV snapshot, and we include this to show you that there are many other products that are in the pipeline. There are 3 other long-acting monoclonals. There's 1 other maternal vaccine, so that we're hoping in the next few years we will see even more RSV prevention products. Now, how do these products work? Well, for the maternal vaccine, the concept is that if you vaccinate a pregnant woman, she's already seen RSV before, and she will get a boosted immune response, high levels of antibody, and she will pass these antibodies through the placenta to the baby. So the baby will be born already with protective antibodies. Whereas with the monoclonal, this is a antibody that's been engineered in the lab to be a very potent antibody against RSV, and it's given directly to the newborn baby as an injection. Both of these are types of passive immunization, so they're based on already preformed antibodies. The vaccine is given either in the late 2nd trimester or the 3rd trimester to optimize the antibody transfer, and different countries have taken different gestational ages as the indication for vaccination. Whereas the monoclonal antibody is given ideally right after birth. It can be given at the same time as BCG or hepatitis B. But if you miss the birth dose, you can also give it at an EPI visit. Both products are given as a single dose, and both products will protect the baby through the first 6 months of life. Now, this gives you the results of the clinical trials of both of these products, and I'm not going to go through all of the numbers. What I want you to take away from this is that against severe RSV lower respiratory tract infection, both products are very effective with efficacy of 70% or above through 5 to 6 months of age. Now, this is a putative timeline to when these products might become available to Gavi-eligible countries and low-income countries. If we look at the top in blue for the maternal vaccine, as I mentioned, it was first licensed in 2023. It started to be used in several high-income countries. Now, here we are in September 2024, and we are weeks away from having a meeting of SAGE, which is the Strategic Advisory Group of Experts on Immunization, which is the main advisory group to WHO on immunization policy. SAGE will review the evidence for both of these products and make a possible recommendation. We don't know the outcome, obviously, yet, but it could be that we would get a recommendation for one or both of these products by the end of September. For the vaccine, this will be followed by a step called pre-qualification, which is more like a regulatory approval from WHO. And I will also I would like to mention that there is a multi-dose vial that is being developed by Pfizer, the company, with some support from the Gates Foundation. And that product is specifically intended for use in a low-income setting. It will be priced accordingly and supplied for those countries. Based on pre-qualification of that multi-dose vial, UNICEF will buy the vaccine and Gavi will co-finance it. And we're hoping by late 2026, early 2027, we will see the first Gavi-eligible countries start to introduce the maternal vaccine. Now, for the monoclonal antibody, the pathway and the timing is a little bit less clear, And that's mostly because it's more expensive to make monoclonal antibodies, and there has been no price commitment yet for Gavi-eligible countries. So right now, the product is too expensive to introduce into these countries. We are hoping, though, that the price will come down. There will be other products coming online, which will help to bring the price down. And so we hope to reach a point maybe a few years after where monoclonals will also be eligible and start being rolled out in these countries. Now, I've mentioned Gavi a few times. For those of you who don't know what Gavi, the Vaccine Alliance, is, it's an organization that started in the year 2000 to improve access to new and underutilized vaccines for the poorest countries. Gavi now supports 54 poor countries with vaccine support. In 2018, Gavi decided, as part of their vaccine investment strategy, that they would, in theory, support RSV immunization. But several criteria had to be met. First of all, there had to be a licensed product. There had to be a SAGE recommendation. There had to be WHO pre-qualification. The cost of the vaccine needed to be in a predicted range. And then, of course, Gavi needed to have the funding. Unfortunately, we never reached number one until 2022. We didn't have a licensed product, but now we do. And in 2024, Gavi has renewed their support through another vaccine investment strategy for RSV. So we need to go to number 2, 3, 4, and 5 to make Gavi support happen. Now, let me turn to what countries need to start thinking about as they start to consider these RSV immunization products. For the vaccine, this is not going to be as easy as other new childhood vaccines that could be introduced right into the existing EPI immunization schedule. This is a vaccine to protect babies, but it's not given to the babies, it's given to the moms. And so what needs to happen is we need to bring in other parts of the Ministry of Health besides the EPI program. We need to bring in the maternal newborn child health programs where antenatal care is given and where vaccines are most likely going to be given. We still need the EPI program because they have the experience bringing vaccines into country, moving it through the cold chain, delivering it to vaccination sites. And we know from the experience of maternal tetanus vaccine that when these two departments work together, we get the highest coverage for maternal tetanus vaccine. Now, there are some advantages to each of these products. For the maternal vaccine, as I just mentioned, many countries, most countries already have a maternal tetanus vaccination program in place. So an RSV vaccination in moms could piggyback onto that. The key difference is that tetanus can be given at any time during pregnancy, whereas RSV needs to be given in the latter part of pregnancy. If RSV vaccination is introduced into the antenatal care platform, it could enhance the attractiveness of mothers coming into antenatal care, where they'll benefit from other services that are delivered in antenatal care. And if an RSV vaccine is included in a maternal immunization platform, it could pave the way for future maternal immunizations, such as for group B strep. Now, the monoclonal antibody given as a birth dose can be given along BCG hepatitis B oral poliovirus. It's an intramuscular injection. It looks just like a vaccine, and so not a whole lot of training will be needed among healthcare workers who already are giving birth dose vaccinations. Both products will protect through the first 6 months of life, where the highest mortality is. Both are passive immunization, so should not have a problem, will not have a problem with enhanced respiratory disease, and only one dose is needed. And both products at moderate pricing have been shown to be cost-effective in LMICs. Now, there are some unique challenges. With the maternal vaccine, as I mentioned, we need to bring in another department. It's not just EPI, it's maternal and neonatal child health. Secondly, because it's only given really in the third trimester of pregnancy, the dating of the pregnancy will be important, and that will add a programmatic step to vaccination. And then lastly, there needs to be attention paid to linking vaccination in the mom, those records, with the child's immunization records. For the long-acting monoclonal, it's given best before a child leaves the birthing facility. But if the child is not born in a health facility, but in the community, it may be harder to reach them with a birth dose. Secondly, monoclonal antibodies are not vaccines, and so the regulatory pathway might have to go a different route in the country and might need to be regulated and authorized as a drug. Third, I've already mentioned the cost and supply barriers to monoclonals, and then for some monoclonals, including nirsevimab, there may be a requirement to give 2 different doses based on the weight of the baby. For both products, countries will need to decide, do they want to take a seasonal or a year-round approach? Awareness needs to be raised about RSV in general for both products. That's where the RSV Roadshow might play a role. And we know that immunization is already a very crowded neighborhood in most countries. Countries are catching up on coverage after the pandemic. Some countries in Africa are introducing malaria vaccine. There is an effort to increase human papillomavirus. So it's a crowded space right now. So I want to leave you by thinking about several things as you think about how to get these products into your country. What is the case to be made for prioritizing RSV in that crowded immunization space? Is it protection of young babies? Is it strengthening the maternal platform? Might it be something else? If both products are available, what product would be preferred in your setting? Where's the strength of your delivery platforms? Do you have a strong maternal vaccination program and an antenatal care program? Or is birth doses of other vaccines already high? How to raise awareness, acceptance, demand? Who will be the local champions to promote these products? Do you need local disease burden data? Or is it enough to look towards other countries? Will you need to do surveillance for RSV? And will you need to set up some safety monitoring, particularly in pregnancy? Is your workforce already overstretched? Do you need to add new people? Do you need to do retraining? Who's going to finance the vaccine? Will it be Gavi? Will it be some other source of funding? And lastly, how do you get the policymakers on board? When to start introducing these products to the NITAGs? So I'm going to end there, and I want to remind you that, as Heather mentioned at the beginning, this slide set, along with all of the other slide sets, are freely available to you. And we are hoping that you will join us in taking this RSV Roadshow on the road. Thank you very much.
Thank you, Danny, for a wonderful presentation. I see a number of hands clapping. Really covered the major issues and the major challenges in implementing preventive interventions widely. So now, just a reminder to people, please put any questions in the Q&A, just type them. We'll try and get to all the questions as much as possible. But what we're going to do now is just reflect from in low middle income country context, some of the challenges and the way forward. And I'm going to start just with a few brief words about South Africa. As Danny has mentioned, similar to other countries, and South Africa was part of the Verge study, RSV is the major cause of hospitalization in children with pneumonia. There are around 100,000 hospitalizations each year. And similar to other low middle income countries, although not quite as bad, around 25% of deaths occur outside a health facility. So a very big burden occurring outside the health facility as well as in health facilities. And of course, this is a huge cost in itself. I just also want to highlight that we are increasingly understanding that RSV LRTI itself is one disease burden, but we also know that RSV is a co-pathogen in all-cause LRTI, and that the impact of RSV is much bigger in terms of disease burden than RSV-specific LRTI. There's data to show that early life RSV pneumonia is associated with recurrent pneumonia, is associated with recurrent wheezing, maybe associated with asthma, maybe associated with lung function impairments. So there's also a long-term burden that I think we don't know whether these early preventive interventions may in fact impact on these. But I think we do need to bear in mind the full burden of early life RSV, LRTI, and the full potential public health value of prevention. And I really, in South Africa, I think that both products are actually at our regulatory authority at the moment. We're hoping for approval of one or both quite soon. And I think for low middle income countries, this is really a question of equity. We know that vaccine uptake lags hugely in low middle income countries compared to high income countries. With the pneumococcal conjugate vaccine, for example, we've seen a 30-year lag. And I think we do have an opportunity now to do better for children for the major cause of pneumonia. So I know you've highlighted a lot of challenges, but I do think that for those of us working in low middle income country context, we need to be very strong advocates for getting these effective preventive interventions out and available to the children who really need them. As you've highlighted, low middle income countries is the area where deaths occur and where children can't access facilities, health facilities. So those are my reflections from South Africa. If I can just add one last reflection, and that is cost efficacy analyses, because these are single doses, right? It's a single maternal shot or a single long-acting monoclonal. Cost efficacy analyses actually show that the products are potentially cost saving and certainly cost effective, even at higher cost than one might anticipate. And particularly in South Africa, this is because of the high cost of hospitalization. So I think we shouldn't just dismiss out of hand, a cost that looks high, but we really need very careful cost efficacy analyses. I want to also now hand over to Dr. Senjuti Saha. Let me hand over to Senjuti. We're very, very fortunate to have Senjuti with us today. She comes from Bangladesh, particularly given all the challenges in Bangladesh currently. Dr. Saha is a molecular microbiologist and an activist based in Bangladesh. She works at the intersection of clinical microbiology and global health. She completed her PhD in molecular genetics at the University of Toronto, Canada, and postdoctoral training at Sick Kids in Canada and Stanford. And it's really a great pleasure to welcome Dr. Saha and ask her for her reflections from another low middle income country context, Bangladesh. Senjuti, thank you.
Thank you, Heather. And it is such an honor and privilege to be part of this, our first roadshow, and be part of this webinar. Thanks to the organizer, Danny, when you were speaking, something that really stood out for me is the use of the word democratic. And when you said that RSV is a democratic virus, so it infects everybody, right, across the world. However, as you mentioned, the outcome is not equal. And you're absolutely right. Heather mentioned that about her experiences in South Africa and other LMICs, and we see something very, very similar in Bangladesh too. When you were also talking about risk factors, while everybody is at risk of RSV, children, preterm babies with comorbidities are more likely to have severe disease, also stood out to me because Bangladesh actually has one of the highest rates of prematurity. So about 19 to 20% of the babies that are born are premature. They're at higher risk of severe RSV infections. And I think this is very similar to some of the other resource constraint settings and LMIC settings. Another thing that Danny also mentioned in his talk is the vaccines will not prevent disease. Very, very important to note. The vaccine will also keep children away from the hospital. And that's specifically important for LMIC's resource constraint settings where we have limited number of hospitals, limited number of beds in those hospitals. So I can give an example from the hospital that I work with most closely, Bangladesh Shishu Hospital and Institute. This is the largest pediatric hospital in the country. It's a tertiary level hospital. It has about 660 beds. And just like Heather said, RSV is also a major cause of hospitalization in this hospital. And we see children in the hospital from across the country traveling from far distances with severe respiratory infections to get care at this hospital. And, you know, of this 660 beds, about 40% of the beds can be taken up by children infected with RSV during peak seasons. So a high burden of RSV we see here, and we see that this children, babies with RSV infection can, you know, stay up to 5, 6, 7 days taking up a bed in the hospital. And I emphasize on this because of another point that I want to make, that each year this hospital sees about 40,000 children who need hospitalization. So these children come to the ER and they need immediate hospitalization. But unfortunately, the hospital cannot accommodate them all. So about 20% or 9,000 of these 40,000 children on average have to be refused admission. Their families have to be refused admission because we just don't have enough beds to accommodate them all, to give them the care they need. And you can imagine during RSV peak season, because all of these beds are taken up by RSV infections, we are unable to admit even more children. And there is data that now shows that children who are refused are much more likely to succumb to the disease, especially if they're premature, if they're neonates in the first few days of their lives, they're more likely to die. So if you're able to prevent RSV infections, if you're able to prevent children from coming to the hospital at the first place, we're not only preventing deaths due to RSV, infections due to RSV, we're even helping prevent deaths from other causes of diseases that might not be preventable through vaccines. And the last thing that I wanted to focus on, and that came up again and again, is financing. This is very different than what most LMICs have experience with, right? Like in Bangladesh, for example, the EPI program is excellent. We have amazing vaccine coverage across the country. Most places over 90%, but it's EPI and not ANC. Our ANC is not very strong. So not only do we need financing for the vaccine, we need financing to actually build that infrastructure, to be able to get to the mothers during that window when we can vaccinate them such that the babies are protected. And along with that infrastructure for ANC, linked to EPI comes messaging. This is going to be a completely different ballgame for us, right? Figuring out how to give mothers, parents, communities, societies the right message to come get the vaccine so that their babies are protected. And it's going to be different for every community, every country, every setting. Another thing that also comes under financing is the supply issue. We will most likely, countries like Bangladesh will not be able to afford monoclonal, so we're going to be dependent on vaccines supported by Gavi and others. But that also means we will be, if we are putting in so much, resources into infrastructure, messaging, we must ensure that there is enough supply such that once the vaccine is introduced, there aren't other barriers, which we have examples of, right? Like things going wrong, companies not giving vaccines or deciding to stop manufacturing. So we have to be very, very careful. It cannot go wrong. And I think now we have the time that we are thinking early to figure all of that out. And, cost for financing for vaccines for RSV is going to be even higher in Bangladesh, because we saw in Danny's slides that we see RSV throughout the year. Yes, there are peaks, but when that peak will come, we cannot predict. Sometimes they come post-monsoon, sometimes they come in winter, sometimes 2 peaks in a year. So we most likely have to vaccinate all mothers throughout the year, and we have a birth cohort of 3 million. So it's going to be a lot of resources that we have to put in. So those are some of the things that I was thinking of when Danny was presenting. I'm going to end here, and maybe I can take questions if there are later. Thank you.
Thank you very much, Sanjuti. And I think this leads very well into some of the questions. The first question actually is from Louis Bont, who asks about the challenges of implementation of RSV vaccines and highlights the lack of awareness So, and the question is, which narratives may help reaching decision makers, in addition to highlighting the huge burden? And maybe, I can add, should we be highlighting these preventive interventions as pneumonia prevention interventions rather than a very specific focus on RSV? I think what we found in low middle income countries is RSV is not widely understood by mothers, but pneumonia is. Danny, would you like to address the issue of raising awareness?
Thanks for the question. I think you're right, Heather, in pointing out that RSV does not have the same name recognition as other vaccine preventable diseases, and that puts it at somewhat of a disadvantage. As you say, we already have a pneumonia vaccine in pneumococcus. So what do we call the RSV vaccine? There was some interesting work that was done by Johns Hopkins School of Public Health in Kenya and Bangladesh, where they asked mothers and caregivers if they knew about RSV, and very few of them knew about RSV. But when they showed a video of a child, a little baby with bronchiolitis, almost all the mothers said, "I know that. I've seen that before." So there is recognition of the syndrome, and the syndrome is severe. But I think the key is, as you say, translating that into knowledge of this is something that can be prevented. Obviously, part of the reason in the group of us who got together to develop this roadshow was because we foresaw that there would be a lack of awareness in many countries. And of course, if you don't know about a disease, you're not going to want to get the vaccine to prevent the disease. So we see this as a key component, just one component of raising awareness at the country level of RSV and RSV prevention.
Thank you. There's a second question also from Louis about antibiotic resistance, which we all know is rising and is a key concern. And he asks, what are your thoughts on the potential of RSV vaccines to impact on antibiotic use, both necessary and unnecessary, and so impact on unnecessary use and antibiotic resistance?
I could take that.
Go ahead, Sanjuti. Yes.
Okay. That's a very, very good question. Again, especially from the perspective of resource-constrained settings and many LMICs where antibiotics are often available over the counter. So a common practice in Bangladesh is whenever a baby or a child falls sick, the parents will go to the pharmacy and buy over-the-counter antibiotics, or even if they go to a community clinic or an outpatient department, antibiotics are given right away. And, especially for viral diseases, because there aren't some immediate tests, rapid tests, antibiotics are administered even in hospitalized children immediately. While I don't know of a lot of data done specifically for RSV, I know for many other diseases, example, typhoid, there is all this work and modeling done that has shown that if the burden of disease comes down, automatically, if it's a high burden disease, use of unnecessary antibiotics are reduced. In case of typhoid, for every true case of typhoid, up to 25 additional children can be treated with unnecessary antibiotics. And I think for RSV, it's going to be very similar, if not higher, because the burden is much higher. So I do think RSV vaccine also has a potential of reducing unnecessary use of antibiotics. Over.
Thank you.
Can I just add, I add? Go ahead, Heather.
Go ahead, please, Danny. No, you go ahead.
I wanted to add one thing. Fortunately, Sanjuti gave me 1 minute to look up something I was looking for by going first. In the clinical trial of nirsevimab, there was a documentation of a significant 24% reduction in antibiotic prescriptions among those babies that got nirsevimab compared to placebo. So I think we do have some evidence that, in fact, antibiotic prescribing and courses of antibiotics will decrease if you prevent RSV. Whether that will impact on antibiotic resistance or not, I think is a secondary question, but we do have some evidence that we would see a reduction in antibiotic use.
Yeah, I was going to add that there's also some evidence from the very first RSV maternal trial recently done, which was not a pre-F, it was a nanoparticle vaccine, the Novavax trial, and that was done pre-COVID. I think the subsequent trials have been done largely during COVID when we saw reduced incidence of LRTI and hospitalizations. But this trial done by Novavax also showed that in women, and this product never came to licensure, but I think one of the important lessons from this trial was that in women who were vaccinated, their infants, there was substantial reduction in antibiotic prescribing subsequently for LRTI in their infant compared to infants who were born to mothers who received placebo. So I think that's another piece of evidence that we have in terms of the impact. There's another question here from Leith Greenslade to ask whether, and maybe Danny, this could be directed to you, whether there's any difference in the impact in terms of lives saved using maternal vaccine compared to a long-acting monoclonal antibody.
Well, I don't know the exact answer. I guess what I would say is I would be a bit careful in comparing the results of the two trials, the clinical trials for the monoclonal nirsevimab and for the maternal vaccine. And the reason is they took place in different populations. The two studies had different inclusion criteria. They had slightly different case definitions for severe disease. None of them actually saw an impact on mortality because they weren't big enough. So what I would say is that both products were very effective against the most severe disease. And so it's hard to distinguish and say one product is more effective than the other at preventing lives. They both will prevent disease through 6 months of age. I think the decision and more lives saved will depend really on which product is available to be used and introduced and what the coverage can be achieved in a country. So if you can achieve higher coverage of one product versus the other in your setting and you can afford it, well, that's the one probably you should go with and will have the greater mortality impact.
So, Jyoti, did you want to add anything?
No.
Okay, then we can move to the next question, which is several years ago, there was an advisory process for a roadmap for maternal immunization with RSV as a consideration. How is this being used and advanced given the many competing priorities and the advances in the last 6 years? So I think this roadmap came from Pat. Danny, could you take that question, please?
Well, if I understand what the question is about, is that there wasn't a large piece of work that PATH undertook called Accelerating Maternal Immunization, or the AMI project, and they identified a long list of gaps that needed to be filled while waiting for a maternal vaccine. I would say that many of those gaps probably still exist. There has been work done since then, but I would say that we do have a product now. We have a maternal vaccine. And so I think that the emphasis now focuses more on at the country level. What are the gaps in a country that need to be filled for that country to make a decision about whether they might want the maternal vaccine? So I do think it's worth going back to that roadmap, looking at what the gaps are, but I guess I would say, I'd caution that we shouldn't make filling all those gaps a prerequisite to introducing these products into a country. They can be done simultaneously.
Thank you. We've got about 10 minutes left, so I'm going to try and compress some of the remaining questions. Um, this question is about, is it essential to assess the immunity status of individuals, particularly antibody levels, in key demographics such as the elderly, prior to initiating vaccine? Danny, do you want to answer that, or do you want me to?
Yes, let me try to answer it, and then maybe you could add if you have thoughts. I don't think that measuring antibody levels is necessary before vaccination of any group, including the elderly, because as I mentioned in my talk, there is partial immunity that forms from RSV infections. RSV infections are happening every 1 to 2 years among people. So the antibody levels are not necessarily determining of whether that person is protected or not. There's no correlate of protection. There's no antibody threshold that we know about. I think the reason older people start getting sick again when they get infected with RSV is that they have more underlying illnesses, and an RSV infection can cause that underlying illness to spiral out of control and land them in the hospital. So I think the short answer is it's not necessary to check antibody levels before immunizing.
Yeah, absolutely. And none of these trials checked antibody levels as a prerequisite to immunizing. They checked antibody levels to document the increase in antibody levels following immunization, but it's definitely not a prerequisite to using these products. There's a question about, could you elaborate more on the safety profiles of vaccine, and especially on monoclonal antibody or maternal vaccine? Is there a difference in safety profiles, and is this a consideration? There is going to be a whole webinar devoted to the use of these products, but Danny, perhaps you just want to give a summary answer to that, please.
Okay. Okay. So taking the monoclonal antibody, I think that the trial did not show any imbalances in safety between the immunization group and the placebo group. In post-marketing surveillance with very large numbers, there have been some reported cases of potential hypersensitivity reactions among babies who got the monoclonal antibody. It's not clear what those are and if they're true hypersensitivity or not, but the product label has been updated to include rare cases of hypersensitivity as a potential precaution. With the maternal vaccine, the vaccine was safe for the mother. There was no imbalance in severe adverse events. And for the baby, there was an imbalance, a numeric imbalance in preterm birth. There was a 1% increase in the group that got vaccine over placebo. I think it was around 5.6% versus 4.6%, something like that. These were preterm birth levels that were lower than the general population, but probably because there were exclusion criteria. There was no concomitant increase in deaths, either child deaths or neonatal deaths, observed in this study between the two groups. There actually were a few more deaths in the placebo group. It's unclear what this imbalance means. It was seen in some countries more than others, and there are studies being planned, introduction studies and post introduction studies to continue to evaluate birth outcomes among children of mothers who got vaccinated.
Yeah, thank you, Danny. If I can just quickly add to that, the imbalance in preterm births was largely driven by the South African data. And I just want to make, I think, one or two perhaps relevant points. The one point is that almost all preterm births were late preterm. So these didn't translate into early preterm births and into death, as Danny has alluded to. And there isn't a clear association between the time of vaccination and birth, preterm birth, or in gestational age of vaccination and preterm birth. And while no underlying biological explanation has been offered, what we have noticed is that these preterm births in South Africa were really coincident with either the Delta or Omicron waves during the COVID pandemic. And so we think that there's some potentially there may be some interaction, and it's, given that COVID is now a different disease and that there are large levels of population immunity, this is hopefully not going to be a major consideration. But absolutely, ongoing post-marketing surveillance will be important, and ongoing studies. A quick question about RSV transmission, Danny. There's a question about what has made RSV emerge, how is it spread, and is it foodborne or airborne? Perhaps can you just quickly address the sort of issues of spread?
Okay, well, I don't know how it emerged. We don't have a ground zero event like we do with COVID. I suspect it's been around for quite a long time. It is transmitted through the air, and it can be transmitted by a sick person coughing or sneezing or even breathing, and is the main way that it is transmitted from person to person. Obviously, because almost all children are infected by the age of 2, it's quite transmissible, and it's unclear whether it's being spread from older siblings or from parents. There is some evidence from some longitudinal studies. I think one is actually from South Africa, that it may be the older children in school who get infected and bring it home to the small babies.
Thank you very much. We have 2 minutes left, so perhaps we need to end now, but much more to come in the next 6 webinars. Let me pull up the next slide. Thank you. So here you see the next 6 to come. The next one is in October. This will deal with RSV clinical disease and burden, and then subsequent ones will perhaps answer some of the questions in more detail. I really want to thank the organizers, the ResVNet Foundation, who've done a phenomenal job in organizing this and in making my task very easy. WHO and Pat for the wonderful slides, Danny for his brilliant presentation, and Sinduti for fantastic insights. And if we could ask, could you please complete the evaluation form? And if you want any of these slides and you want to start advocating for RSV preventive interventions in your country, there is the website again. We'd ask you please to complete the poll. It's just one question: how useful was this? And we'd welcome any comments to make this even better for the next 6 ones to come. Thank you very much, and I think I'm exactly on time, probably for the first time in my life. Thank you hugely to everyone who's made this possible, and please complete the poll. Thank you everyone for being on and for the great questions.
Thank you.
Thank you.